Most of you, I would say, know me as a pediatric surgeon or a fetal surgeon and a stem cell scientist. But today, I want to tell you about another journey, about my travels in the world of global surgery and what I have been doing for this past year, in addition to my sort of side job as a pediatric surgeon and a department chair and a chief of surgery here, and as the president of the American Pediatric Surgery Association, and with that powerful bully pulpit that the presidency accords one with this honor. And how all of this experience has brought me to a clearer understanding of the challenges of caring for children in this country. This morning I want to share with you a vision for our future as a professional community and as a society. And in the words of David Tapper, who was a former president of APSA, I want to propose an audacious goal. As defined by Webster, an intrepidly daring, spirited, adventurous goal that shows contempt for the restraints of law, religion, or decorum. So be forewarned. David Tapper was an accomplished surgeon. He was also my first and most important mentor, the first surgical feminist I met, and my constant inspiration to strive for the seemingly unachievable goals. And in his 2003 APSA presidential address, which was entitled The Achievement of Audacious Goals, which is why this is Audacious Goals 2.0, he indeed inspired us to strive for the unattainable, and I'll talk more about that. Interestingly, his presidential address was delivered just months before his tragic and untimely death from cancer at the young age of 57, which is part of what inspired my remarks today. In his presidential address, David challenged APSA to imagine what could and should be. Today, I issue a different challenge, to look beyond the differences in children's surgery around the globe to the common challenges and unite around an audacious solution. So let me start with the story of a boy from Bangladesh. And I had the privilege, when I initially presented this presentation, to have his professor, Professor Tarmina Banu, who's shown in the middle, actually fly from Bangladesh to present this story herself. So I'll do my best. This is a story of a baby born with a cleft lip and a small axillary tumor. Now, this would be common almost anywhere. He was one out of 4 children. He was born in 2010. They didn't think much about it. They didn't have much money, but they finally brought him to the hospital when they couldn't ignore it anymore at 5 years later. And then you see a picture of him with this large tumor. And now this boy was incapacitated with this tumor. However, the operation was delayed because they could not arrange blood donation. And in Bangladesh, you had to provide your own blood for blood donation. So they had to leave the hospital. The parents were garment workers. He was brought in again after 5 months because he developed chest infections. And he required an additional stay for treatment for these infections related to this. The mother, of course, lost her job. In this time period, another child was injured. An older sibling was sent out as domestic help, and the father incurred as much debt as he could to help support this child. Eventually, the father himself lost his job because of the frequent visits to the hospital. And as much as this is a story that happened in Bangladesh, it doesn't take much to appreciate that this is a story that happens all around the world. As a trainee and a surgeon, and now the president of the biggest children's surgical organization, I have had the opportunity to collaborate with peers from the most privileged and the most impoverished countries in the world. And one of the most impressive lessons that I have learned in my global health journeys is that my international colleagues are often the best equipped to identify the right treatments for their patients in their practice environment. And each practice environment is unique. So let me tell you one of my stories. As a visiting surgeon to Senegal in 1989, I once brought some fancy plastic silastic sheeting to make silos for giant omphaloseals. That's how we were treating them here. Preemptively congratulating myself on what a great idea that was to bring the fancy equipment. Tragically, my patient died, and the local hospital did not have the ability to ventilate or sustain the already malnourished child for the time it took him to recover from this major surgery. The history of global surgery is replete with such stories of outcomes compromised and lives lost because of the best intentions of international do-gooders. I, and many of my colleagues working in global surgery, have since learned that local innovations are often the most successful, less morbid, and more cost-effective. Indeed, the historical teaching in the United States that giant omphaloseals must be urgently closed lest there be loss of domain leading to the intestines in a wheelbarrow syndrome was disproven in places like Senegal. And patiently just painting omphaloseals, these big abdominal wall defects, with betadine and applying compression ultimately results in closure for almost all the defects, leaving a simple ventral hernia that can be repaired when the child is older. In a similar vein, I believe that the lessons learned from global pediatric surgery apply to both low and middle income and high income countries, and that by heeding these lessons, we can collectively transform care for children around the world. 2015 was indeed the year of global surgery. The World Health Organization published the DCP-3, which catalogs the world's entire disease control priorities. And for the first time ever, an entire volume was devoted to surgical disease. And I was privileged to be able to write the chapter on congenital anomalies, on birth defects. And pediatric surgeons wrote many of the other chapters as well. The global health world was starting to appreciate that there was more at stake in the world's diseases than just AIDS, tuberculosis, and malaria. According to World Health Assembly Resolution 68.15, access to emergency and essential surgery for the first time was declared a human right. And perhaps most importantly, the Lancet Commission on Global Surgery showed convincingly that investing in surgical care was affordable and an indivisible and indispensable part of healthcare. I'd like to show you a video produced by the Lancet Commission that describes the current state of surgical care in the developing world.
Over the past 2 decades, global health has focused on individual diseases. Surgical care has been afforded low priority in the world's poorest regions, leaving 5 billion people without access to safe, affordable surgical and anesthesia care. Patients requiring surgical treatment will face multiple hurdles: delay in seeking care, delay in reaching care, delay in receiving care. Reaching the hospital does not guarantee treatment, as many lack the proper infrastructure to provide emergency surgical care. As a result, many easily treatable conditions become diseases with high fatality rates. As many as 90% of maternal deaths could be averted by timely intervention. For those who successfully obtain treatment, 1/4 will experience financial catastrophe as a result of receiving surgical care. To save lives and prevent disability, an additional 143 million surgical procedures are required annually in developing countries. Today's surgical workforce would need to double in 15 years to reach our target of 80% coverage of timely access to essential services by 2030. The total costs required to reach these targets are significant, at approximately $350 billion by 2030. However, the costs of failure are even greater. The lost output will cost developing countries an estimated $12.3 trillion. Investing in surgical services is affordable, saves lives, and promotes economic growth, making surgery an indivisible, indispensable part of healthcare.
But what about children? 1/3 of the world's population are children, and the majority of those children live in low and middle income countries. Indeed, children under the age of 18 constitute more than half of the population in these low and middle income countries. These children represent the future for their families and for their communities. If surgery has been called the neglected stepchild of global health, then children's surgery is the child still unborn. Addressing the unmet need among children is particularly important because simple procedures, such as removing an appendix or stabilizing a fracture, can radically alter the course of that child's life and enable them to contribute and participate in their community's social and political and economic network for years. However, children are often assumed to be healthy because of their age, and for that reason, perhaps, have often been overlooked as a target population in prior efforts to expand access to safe surgical care in low and middle income countries. Even when children's surgical care is the primary focus of well-intentioned initiatives, whether by individual practitioners, non-governmental organizations, or other countries, these efforts often stumble because they are largely directed by the global north, by us, and making recommendations for interventions for the global south. And we just talked about the fact that they understand their context and their needs much better than we do. So, as many of my colleagues who are engaged in international work can attest, the global landscape is littered, literally, with the abandoned detritus, the rusted ventilators, the unrepaired incubators of previous medical missions. A recent survey conducted by the APSA Global Surgery Committee showed that half of the membership of the American Pediatric Surgical Organization was actually interested in global surgical activity. So the question is, how can we do global surgery for children better? At the 2015 British Pediatric Surgical Association meeting, I was asked to describe some of the pressing issues for pediatric surgery in the United States. And in addition to mentioning the current debate about the workforce in the US, I highlighted the non-operative umbilical closure for babies with gastroschisis, newborns with babies born with their intestines out. And I couldn't avoid noting that while the fatality of this disorder in the United States has dwindled to almost zero, the overall mortality for this anomaly remains close to 95 or 100%, just because half of the world's children don't live in the United States. They live in low and middle income countries. So even though we've solved this problem here, we haven't really impacted the overall mortality of this disease. Struck by the injustice of this comparison, that a newborn's chance of survival is so predicated on the lottery of the circumstances in which they were born, I and fellow pediatric surgeons Dan Panaro from Canada and Kokil Laku from Great Britain got together, and we began a conversation about what could be done to tangibly improve the care for children everywhere. These conversations eventually culminated in the founding of the Global Initiative for Children's Surgery, or GICS, or JICS, or we don't really know how to pronounce it. But GICS is based on a vision of children's providers from low and middle income countries as the primary drivers in the development of new programs and initiatives matched with potential funders, likely from high-income countries, and low and middle-income country surgeons as the expert guides to the most effective interventions in their practice contexts. GICs involved providers engaged in children's surgery, from neurosurgeons to urologists, from anesthesiologists to physical therapists, not just specialty pediatric surgeons. And the core goal of this new organization was to initiate and accelerate long-term sustainable progress towards safe surgical care for children around the world. We began by developing a sequential operational plan, a very surgical approach to a problem. We're going to collectively analyze the current state of children's surgical care around the world. 2, develop global and local priorities for improving surgical care in low and middle income countries, and then to identify and bring together resources to achieve these goals. A small group set about organizing an inaugural in-person priority setting meeting with geographically diverse providers in low and middle income countries practicing in a variety of specialties. Prior to the first meeting, we sent out a 19-question online survey. We figured that nobody can do more than 20 questions on a survey. And this was sent to all the invitees from all over the world. And what's amazing is, in today's economy and connected world, it's not that hard to have an international online meeting. These survey responses were quantitatively and qualitatively analyzed to identify the key themes and then set the agenda for this upcoming meeting. All of the providers responded to the survey cited that workforce issues were the primary factor preventing children from receiving the needed care. Respondents also identified facility capacity and patient factors, the overall function of the healthcare system, as well as challenges in conducting research and dealing with communicable diseases that affected surgical patients as factors that prevented children from getting the surgical care they needed. More specifically, the inability to provide things like total parenteral IV nutrition was the most common identified supply or equipment deficiency. This was across the world, whether it was Bangladesh or sub-Saharan Africa. 95% of participants reported no access to a pediatric intensive care unit, and 88% indicated a lack of access to a NICU, or a neonatal intensive care unit. And over 60% of the respondents, more than half, indicated that they didn't even have basic surgical equipment and instruments that were sized appropriately for children. When asked which were the most difficult patients to treat and which were the most neglected, they often identified neonates, the newborns, as well as patients with congenital anomalies, patients born prematurely, and patients with tumors or burns as particularly challenging to treat. You'll notice, if you look at the slide here of congenital conditions and their relative mortalities, you'll see these are all newborn birth defects, but you'll see that gastroschisis, babies born with their intestines out, is not even on this slide, because most of these children do not even make it to the hospital. They are dealt with in their local communities where they're born, and they don't survive. This is a true hidden mortality. They're not even counted on the death and birth registries. It's as though they didn't exist. Additionally, poverty-stricken patients, patients with psychosocial issues, and rural patients were identified as neglected and difficult to treat populations. So, what are some effective solutions? 4 main areas were identified as the targets for solutions to these challenges and to set the agenda for the subsequent in-person meeting. These targets are the surgical workforce, supplies and equipment, accessibility to care, and healthcare system infrastructure. So a hospital is not good enough. You need the whole system infrastructure as well as research. Increased in-country physician training was the most commonly identified method for improving surgical workforce. Indeed, respondents repeatedly voiced concern that the current scarcity of in-country training opportunities and the reliance on overseas training, sending their best and the brightest to a first world country, contributed to an ongoing problem of brain drain, in which the providers from the low and middle income countries choose to stay in the country of their training, and they don't return home. This practice has to stop. The first GICS meeting was, in fact, occurred in London. This was because the Royal College of Surgeons graciously donated meeting space and subsidized housing, because of course our LMIC participants couldn't afford to fly to London and find places to stay. So we raised all the money. By the way, if you've never been to the Hunterian Museum in London, it's a medical museum. I heartily encourage you all to go there the next time you're there. It's very interesting. Much to our dismay, raising funds to support the travel for providers from low and middle income countries proved much harder than any of us imagined. We thought this would be a no-brainer. Of course people would want to support improving surgical care in middle income countries. Ultimately, personal donations from members of the organizing committee supported the majority of the travel costs for the LMICs. The inaugural two-day meeting of GICS occurred just after the APSA pediatric surgery meeting the following year in 2016. We had at this meeting in London over 50 pediatric surgeons, urologists, anesthesiologists, plastic surgeons, critical care physicians, and nurses. They were from 24 countries ranging from Uganda, South Africa, Bangladesh, Peru, Papua New Guinea, as well as Canada, Britain, Germany. In the United States, we had a relatively small proportion of providers. We identified a large group of individuals who presented the challenges in their environments and some of the strategies that they employed to solve them. In Vanuatu, we learned about the challenges of inter-island transport. In Bangladesh, we discovered the betel leaf stoma care approach and the bananagram method for determining whether or not it was safe to close a stoma, as well as results of sort of rural training efforts that had been done in Bangladesh. So Bangladesh is a country that has one major huge city and then a very rural population. In Congo, we were introduced to the heroic efforts of surgeons who work hard to improve their country's image through the provision of great care to their children. Each working group was led by a participant from a low and middle income country, and iterative working group discussions interspersed with large group feedback culminated in the identification of the priorities for each topical area and tangible future work products. Envisioned work products included white papers, collaborations, consensus statements on the optimal minimal resources for surgical care, children's surgical training courses, collaborative research, and the development of a social media and web presence. So what were some of the outcomes? Identified strategies included developing programs to train more providers and programs for skill building for current providers in their environment, founding dedicated children's hospitals and disease-specific centers of excellence to deliver care and train interdisciplinary teams of providers, directing financial resources to purchasing equipment, particularly imaging equipment and disposables, those instruments that they didn't have. And things like investing in renovating new operating rooms, increasing intensive care units and burn units, creating networks with a central hub and rural clinics, and to develop national birth defects registries so people could at least have an idea of what's the baseline that we need to deal with. And most importantly, it was a universal consensus among all these providers that providing free care to children so that families would not end up impoverished like our family from Bangladesh was a priority. Approximately a year has passed since that first meeting was established from GICS. And in that time, members of the groups have facilitated 3 new training partnerships between the UK's Royal College of Surgeons in India, between Uganda and South Africa, between Kenya and Uganda. Many of these are country to country. And we've expanded the Global Pediatric Surgical Network to include training opportunities, not just mission trips. The second in-person meeting was arranged and held at Washington, D.C. This time it was hosted by the American College of Surgeons and supported by the American Pediatric Surgical Association. At the second in-person meeting, working groups composed of providers from different surgical specialties and representatives from NGOs, often funding or corporations, got together to determine the minimal standards of workforce training. The plan was to make this meeting one to mix the providers with the possible implementers or funders. So at our meeting, we determined the minimal standards for workforce, for the complexity of surgical procedures, for the equipment, for the need for allied health professionals in community-based centers, often known as district hospitals, as well as secondary and tertiary hospitals. These discussions resulted in the development of the Global Optimal Resources document. Again, this is a representative of where all of these providers came from to this meeting and the optimal resources and the different levels of care that people are seeing. Just to give a little background on Vanuatu, as I mentioned, this is a country that's mostly an island country, so inter-island transport, imagine a baby born with a birth defect on one of these small islands, is a huge challenge for them. In Bangladesh, we talked about, here's the stoma care with a betel nut leaf, which actually has anti-inflammatory properties, so helps keep that skin inflammation that I think we've all seen in patients with stomas. The bananagram, if you don't have access to radiology material or the dye that we often use, this was a way to determine if the banana stuff goes in one side and comes out the other side, probably you're okay, that it's fully connected. And then just ways to figure out how to do neonatal surgery if you don't have anesthesia, what can be done under local anesthesia. And again, we talked about the outreach programs to connect people in the rural parts of Bangladesh to the main cities. In the Congo, again, do you want to be known as the world's most dangerous city? Or perhaps, welcome to Goma, where creative and dedicated people are working to improve the lives of children. So, GICS had the vision that every child should have safe and easy access to surgery. We developed the Optimal Resources document, which defined these needed resources in every level of a national health system and within each specialty in order to provide safe and high-quality surgical care to children throughout the world. For those of you who have been involved in this and have heard of the Children's Verification Program in the United States, this is very similar to that kind of effort, figuring out what are the resources you need at each different level of care to make sure that if a family takes a patient to this hospital, they know there's a pediatric neurosurgeon on staff if that's the level of care that's needed. Originally organized, you can see that the scope of surgical services were based on what you would anticipate. So what was basic surgery? what was intermediate surgery, and where could it be done, and what did you need, and what needed to be transferred. And each different country was able to identify what kinds of levels of care were needed and what were the age cutoffs for children's hospitals in their environment. Originally organized by the team that you see here and supported by an amazing group of global residents from all across the country, the residents indeed were the true power behind this effort, GICS now consists of 153 members from 44 countries. And while the need for improved surgical capacity, data collection, and collaboration have been recognized previously, GICS is unique in the professional and geographic inclusivity of its membership. It's not just Westerners deciding what they think other people need. Its emphasis is on realistic implementation through low and middle income country provider leadership and its bottom-up identification of issues and solutions. GICS has thus far relied on volunteer labor and personal donations. The organization is now in the process of becoming incorporated to be a separate 501c3 organization so that it can try to fundraise on its own. Incorporation will allow us to publish the optimal resources document that we've created for the world to be done in collaboration with the World Health Organization, and planning for GICS 3, the third meeting, is underway. All of these things will move this organization to the next level. But what about care for children in the United States? In reflecting on the formation of GICS and my term as president, I was struck by the realization that the solutions that we were collectively devising to improve children's care in low and middle income countries also holds promise for improving the delivery of care to the most impoverished and vulnerable children in the United States. And what you can see from this slide is that if you take the observed to expected mortality for children under the age of 5 and you adapt it for socioeconomic and educational expectations, the highest mortality is in the orange, and you can see that the majority of that is in the United States, and it is on par with countries like Uzbekistan, Turkmenistan, and South Africa, rural parts of South Africa. It is astounding, and we should be ashamed. Anyone who has worked at a Shriners Hospital can anecdotally attest that for the most impoverished children in this country, for the uninsured children in this country, the high-quality surgical care remains largely inaccessible if it weren't for hospitals like this. I have now personally operated on over a dozen children over the age of 5 with undescended testicles. Most of these boys will be infertile. If we look again at that map of underage mortality based on socioeconomic index, you can see again how embarrassed we should be at the results for the care of children. So it forces one to ask the question, within the United States, what are the barriers that prevent these children from receiving timely and appropriate surgical care? A shortage of trained surgeons in all environments, inadequate health insurance coverage, and low patient socioeconomic class have all been identified as challenges to the provision of high-quality care to children's surgical care. The work of GICS has provided a number of key proven strategies for improving accessibility and quality of children's surgical care. In the United States, one of the most timely and relevant of these strategies is initiating the establishment of universal coverage for children's health care. For some Americans, the concept of universal health care conflicts with that fundamentally American value of meritocracy and individual choice. However, children are innocent. They should not be disadvantaged based on the sheer chance of being born to parents without the means, or sometimes more importantly, just the know-how to ensure that they receive essential health care. Medicaid has been associated with a significant drop in infant mortality in this country. While federal legislation mandates that impoverished children be considered eligible for Medicaid coverage, individual states retain the right to establish the need, the level of impoverishment required to qualify as needy. And whether a family qualifies for Medicaid and the amount of support they receive, therefore, varies dramatically by state to state. And as a result, children still fall through the cracks. In 2015, 1 in every 20 children did not have insurance. In the United States, uninsured children are 3 times more likely to die following pediatric surgery. And this excess mortality that's suffered by uninsured children accounts for almost 40% of the child deaths in the United States. And even those with Medicaid experience disparate outcomes compared to their peers with private insurance. These are all data from the United States database. And the children who are on Medicaid experience greater morbidity following surgery and are at a greater risk for perioperative death, just based on nothing but insurance status. So the future of American healthcare system is unclear and is being played out in our government right now. As Congress attempts to repeal and replace the Affordable Care Act, that effort has floundered. It is new again. And one thing that you can hear is that the reduction in dollars to Medicaid is the most significant. And the majority of people on Medicaid, what no one has been willing to say is that what we're really talking about is reducing the care for children. Medicaid is code for children. We are going to sacrifice the lives and the future of our children in order to support our system. I believe that this issue of ensuring coverage and access for each and every child cannot wait. No child should be prevented from accessing essential health care because of financial concerns in this country or anywhere. And so I propose an audacious goal. Let us pilot MediChild, a national healthcare system of coverage for children under the age of 18. This system would ensure that all children, regardless of their family's employment or location or their type of health insurance, would have access to high-quality care. A child's access should not be limited by the fact that her parents are temporary vineyard workers, as here in Northern California, or that the family moves across state lines from time to time because her parents are in different stages of their medical training. They had to move when they matched in residence to some other place, and now their child, who might have some special needs, isn't eligible for coverage in another state. Or perhaps they've reached their $1 million care cap. That's easy for a child with a handicap to acquire, as you all know. Or that perhaps parents juggle multiple part-time jobs, none of which provide regular health care benefits. We think of Medicaid for the poorest or the most impoverished of our patients in the United States, but it's not true. Just being in between jobs can put you in a situation where you don't have insurance, and that can happen to anybody. In order to prevent these types of children from being left behind, this program must be federal, like Medicare. It's got to be Medicare for children. I can't solve all the problems. We'll leave the people out in the middle, but let's, at the moment, we'll let Congress fight over that. Let's take care of our patients over 65 and our kids under 18. Beyond funding, MediChild must mandate that this care be delivered through an integrated and coordinated system to reduce duplication, to prevent redundancy, to create a national healthcare system for children. Let's just pilot it for children. We won't worry about dealing with this on the adult side. It's too big a political thing to handle. Just as GICS developed the optimal resources document for other places in the world, and it outlines a system for certification at different levels of hospitals, we can, in low and middle income countries, so too should MediChild ensure that children in the United States receive the care they need at the hospitals best suited to addressing their medical needs. And we've all seen children that have come from well-intentioned adult hospitals or rural general hospitals who tried to do the right thing, but they just didn't know what they needed to know, or they just didn't have the right equipment to take care for children. We can build on the foundation of the optimal resources documents and the NISQIP programs and many of the verification programs that already exist in the United States to create an integrated system to achieve this goal. With an integrated system, we can rationalize resource distribution, avoiding costly competition and duplication. We can train the right providers for the right environment. I am not the first person, in fact, not even the first APSA president, who suggested that children deserved accessible, affordable, high-quality care. And going back to my original mentor, David Tapper, in his presidential address 15 years ago, set out his goals, that all children with a presumed diagnosis of intussusception should be rapidly transferred to a major children's hospital, because we know that if those children are operated on in community hospitals, they have a 50% greater chance of having bowel resected unnecessarily. He proposed that all children under 7 should be operated on only by specialty certified children's surgeons, not adult surgeons doing it as part of their job on the side. And that all children under 4 who required surgery should be anesthetized with people whose full-time job or who had specialty training in pediatric anesthesia. And 15 years ago, that health care for children was a right and should be funded. And indeed, in 1996, similar recommendations were made as well. The need is as pressing it has ever been. It hasn't changed. It hasn't gotten better. The time is now. Let us truly live up to the greatness we as a country wish to embody. We can do it by leading the world in the development of an integrated healthcare system for our most vulnerable, innocent, and important citizens, the ones that represent our future, our children. So I have proposed an audacious goal, and I invite you to join me in striving for its realization. We're going to figure out how to get this done. The lessons learned from our international efforts to improve capacity, accessibility, and the quality of children's care should be shared across professional, economic, and political boundaries. Within the United States, we have the opportunity to be one of the strongest voices for this vision. Thank you for the opportunity to share this conversation with all of you.